Are you going to give a countdown?
Yes.
Yes. Good evening, colleagues. Welcome to another Heart Failure Masterclass by Heart Failure Association of India. The object of these classes or discussions is to induce deductive thinking, interpret history properly, interpret physical science, and decide what are the relevant investigations and how they should be interpreted. I think in today's time, it is especially important because with over reliance on technology and investigations, many times we forget the basics. There is so much of information which our master teachers get out of the history and from the physical examinations before going on to other investigations. So, over to you, Venu, to conduct the session.
Thank you, Chopraji. As usual, we have 3 sessions this evening. First is the biostatistics talk, Statistical Thinking in Health Service Research by Dr. Jissa Viti, who is a epidemiologist in Sri Achuthamenon Center, Trivandrum. Then this will be followed by a case presentation. The presenter is Dr. Rajeshwari, who is a senior resident from JIPMA Pondicherry. The student panel is from KEM Hospital, Mumbai. And the examiners are Dr. Jagan Mohan Taragan, Dr. Sudhir Kumar, Dr. Ajay Mahajan, and Dr. Santosh Satish from JIPMA Pondicherry. This is followed by an OSCE, which will be presented by Dr. Bhagavanti Prasad, who is Assistant Professor of Cardiology at JIPMA Pondicherry. This is the program schedule that we have. So first we will have the talk on biostatistics. I would like to invite Dr. Jissa Viti, who is an epidemiologist and scientist D at Achuthamenon Center for Health Sciences Studies, Trivandrum. She will be talking on statistical thinking in health science research. Over to you, Dr. Jissa. We are looking
Thank
forward
you.
to it.
Thank you all, and good evening. So first of all, I would like to express my sincere gratitude to the HF Society. For giving me this opportunity to share my thoughts on statistics with this expert panel and with the students. Okay, so let me just share my slides. Okay. So is it visible, sir?
It's visible.
It's
Yeah.
easy.
Okay. So statistical thinking or statistical planning, in title there is a slight change in that word, but let us discuss about what kind of planning or what kind of thinking we need to have when we plan our research. This is what I am broadly discussing today. So the first thing is we should understand that statistics is not begin at the phase when you completed your data collection and you are sitting with your data. That is not the time you have to think about statistics. So statistical thinking should come before data collection, especially saying that, or particularly when you plan your research, that time itself you have to think statistically. And that statistical planning is a process, okay, and that in that process we have to decide how are we going to collect our data, how are you going to measure the important variables in our study, and once we have our data, okay, organize your data and what are the methods I may apply to analyze my objectives, okay, analyze my data to get the the findings or get the findings according to my objectives, and how should I interpret. So all these things we actually have to decide well before the conduct of the study. So that is what here today I am going to briefly explain. We all know all these things, but just summarizing these things, organizing all these points in a manner so that we can remember those things, and also we can find some important points that sometimes we may not think about. Okay, so the planning will give us a valid and reliable results. So a valid and reliable outcome to your research. That is one important thing about statistical planning, or that is the important thing that the statistical thinking or planning well before conducting the study can contribute. Then we can the optimal use of time, money, and participants, that is the efficient use of the resources, that also a well planning, statistical planning can ensure. Then of course it is connecting with that, the adequate sample size. We don't want to include too many participants, or we don't want to include very less inadequate number of participants into your study. It should be adequate to address the research objectives scientifically. So that is one another thing. There also the statistical thinking should come, and it should be ethical also. We have to think about different ways, especially when you are talking about sample size, that also is connected with ethical ethics, because sometimes we may have to, we are including so many participants unnecessarily that we can avoid, or we are wasting our time, but we are wasting our resource and time by conducting a study without a statistical planning, and finally we will come up with some results, and that is not scientifically valid. So we have to avoid all these things, and especially we have to think about what are the possible biases that can happen during the research, especially while collecting the data or measurements and etc. And the overall, the important thing is that we all are, we all want to publish our research in good journals, and so the stronger study design and good statistical planning can increase the publication potential. So that's how, or that's why the statistical planning, it is a matter of concern. And so where do we, or when do we think about statistics while we plan our research? So when you think about your research question, or when you frame your research question, see, that time itself we can convert some fragments of that research question to some important statistical aspect. For example, here I have a question like, does regular yoga practice reduce systolic blood pressure? Okay, that is one research question. A researcher is asking, and then immediately, see, when we have a properly defined research question, okay, we can easily identify many things. For example, what is the study population? Okay, that is there in that research question. We can easily pick, okay, hypertensive adults are the study population, and what kind of exposure you are giving, what is the intervention, and what is the comparison group, and most importantly, how are you going to find the answer to this research question? So what is, in terms of statistics, we have to think about what is the outcome variable that I'm going to compare, or that I am I am taking as taking to show the results, okay, to answer this objective. So when we frame a research question with all these components, that is very easy for the researcher as well as for the reviewer to evaluate the proposal further. Okay. And also in many other parts of the statistical planning, such a very well structured research question is important. Okay. Yeah. So in this previous research question, again, so we define what is a study population, what is a comparison, what is the outcome of interest. And then when you have the idea of your outcome of interest, we have to think about, okay, so this is my outcome of interest, and what is the nature of that particular outcome of interest? What is the nature of measurement? Okay, is it a numerical measurement, continuous measurement, or is it a yes or no kind of question, a categorically defined outcome? So what is the nature of that particular outcome variable? Okay, so there we have to think about, then that will help us to think about, okay, what statistical summary measures we will consider there to answer my research question. Okay, so for example, here, if it is, since SBP is a continuous variable, we can think about, okay, mean comparison may be an appropriate way of answering the study objective. And for statistical inference, we can think about, okay, student t-test, okay, can be applicable. Or if the outcome is analyzed as a categorical variable, like a binary variable and all, we can think, okay, if I am analyzing my outcome variable in that way, then I may report the proportion, the percentage, and we can have a comparison of the proportions between the two groups. Okay, and then probably I can go on with chi-square test. So this is how we, everything is connected with this research question. Okay, now, and also statistical planning, in that, in statistical planning, we have the study design. We have to think about the study design. And again, the study design, how the study design is important in statistical planning. We have to think about that. Correct. So, how to do the sampling process. Okay. And the required sample size, estimation, and what kind of analysis I may apply. All these things will be connected with the study design. So again, when you have the study design in place, okay, when you decide the study design, again, you have to connect it with all these statistical matters. Okay. So now, earlier we said, no, the most important thing is then identify the nature of the outcome variable. Okay. Or the most important exposure variables in our study. Okay. So we have to think about, and for example, if the variables are continuous in nature, see why? Because, when we write a proposal, especially I'm telling to the students, when we write a proposal, there is many places, like many sections, like you have to describe the sampling plan, you have to describe the sample size calculation and justification. And then you have to describe the statistical methods that you may apply in your research. So if you have to think about that statistical methods that I may apply in my research is connected with a clear definition of the variable of interest, or at least, how to think about the outcome variable or the most important variables you are measuring as part of your study to address your research objective. Okay. So, for example, if the variable of interest is continuous, okay, you have to think about what are the summary statistics I may use. Okay. And what are the statistical inference methods, okay, that I can use for generalizing my findings. Okay. If it is a categorical variable, then we can think about, okay, we may present the frequency and percentage, etc. And I may report the confidence intervals for the prevalences, okay, or the proportions that we are estimating from our sample. And if that proportion comparisons comes in place, then you may use some chi-square test or Fisher. Or now, again, in the previous case or in this case, appropriate regression modeling. If the study warrants such regression modeling, we may use such methods. Yeah. And if the variable sometimes may be an ordinal variable, okay. And then appropriately, we can think about what kind of summary measures I may use, or what kind of summary measures are appropriate for using in that place when the nature of the variable is ordinal. And especially in health science, medical research, we often do survival analysis, time to event analysis. So if your study plans that kind of research, or the research objective is focusing on time to event analysis, then you have to think about what is the definition, what is my outcome variable. Okay, and you should have a clear definition of all other important indicators. Okay, so like what is the starting point, what is the end point, etc. And also we have to think about, okay, what is the most important statistical methods I'm going to apply in my research. See, what I'm saying is we cannot actually write everything when you write your proposal, but according to your research objective or the research question, we can think about, we can actually say, I am probably doing these kind of analysis because those kind of statistical methods are appropriate for answer this particular objective. So that kind of thinking should come. That's why we always have a statistics, short courses and all, or a statistical background is necessary for the researchers. That's why, because we have to think about what I am doing in the future. Okay, so that is about variables and analysis plans. So the most important point I again have to emphasize here is, according to your research question, what are you going to measure? What is the most important variable in place? And what is the nature of it? What kind of summary you will, or what kind of statistics, that statistical measure you apply there to summarize your findings, and for statistical inference, what would be the appropriate method? Okay, right. Now, again, coming to the sample size planning, this is one very important area where the researchers most often need some advices from experts like statisticians, or those who are really having some experience in experience to advise you regarding this. Okay, so again, what is sample size? We know the size, the required number of participants to be included in your research. And as I said earlier, too small, you may not get a scientifically valid result. Too large, then it will be a waste of resources and time. And also, it is not ethical to include so many people unnecessarily into your study. And hence, the sample size planning has all these important aspects, like scientific aspect, economic aspect, and also ethical aspect. Now, how do we find sample size? Okay, the sample size is not like a magic number that we get from somewhere. Okay, we are just picking something from somewhere. It is not the way how to approach the sample size planning. It is connected with, we should understand that it is strongly connected with your research objective or your research question. And what is the nature? What is the study design? What is your objective? What are the kind of measurements you are taking? What is the outcome variable or the variable of interest? What is the nature of that variable of interest? All these things. Okay. And then there are many statistical assumptions. Okay. We may also have to think about, or we have to find, or we have to justify, or assume, we have to assume what would you expect. Okay, that is very much important because a formula-based sample size estimation needs so many such information. It's not just blindly we are putting some information into the formula and giving some numbers. It's not like that. So a very thorough understanding or a very clear review on the literature or the background of your research, and whether you have, you have to find some valid assumptions about the expecting result. Okay. So the expecting result, meaning that you have to think about, then you have to think about what kind of analysis I am going to perform at the end of my study or once I complete my data collection for answering my research question. What statistical method, what summary statistic I am using for answering this objective, and also what inference method I am applying there to generalize my result. Okay, all these things are very important. It is needed. And then we have some statistical assumptions again, like, margin of error concept, margin of error or statistical power, significance level, etc. So all these are, connected with the requirement. Not all research questions need all these things. Like it depends upon the scenario. We should have clear idea about what is the research, what is the statistical method you are applying, what is the statistical inference method you are applying, and what is the anticipated results. Okay, and then we have to ensure that when you do the research, you may find this result, but I have to ensure the statistical significance, statistical power, or I ensure that I have a decisive level of margin of error, etc. So that is the concept of sample size planning. Okay. And of course, sometimes, especially in medical research, we may not have any previous studies. This may be a new study, or you have to think about sometimes, or I had seen this many times, like the student may be doing a study including all patients. Okay, for example, patients underwent a particular surgery, and in the last 20 years there will be only 30 people available. Okay, only 30 such surgeries were done. So then the researcher want to do a study on those patients. Okay, so then see, actually we have to think about whether there is a sampling process possible there. It's actually you are covering everybody, all people. Okay, and what is practically, what is logic? Is it logical to think about calculating a sample size then? See, these are some of the questions I always, questions raised in my mind especially when students come up with some comments from the reviewers about sample size justifications. Why you did not apply any statistical formula in your context and all. So what I am thinking is, like, in the practical scenario, it is always important to clearly define your research question so that we can easily understand whether such statistical assumptions are possible to find the sample size. And you have to think, you should also note that one important point, that the sample, you are picking a sample from a study population. So what is the adequate number of sample, okay, to sample from that target population? So that is a concept. And also this sampling is assumed to be, or it is a fundamental concept that your sample is a random sample. So I'm going to the next slide to tell that. But what I'm saying is, most important thing is, once you write a proposal, how to reach the sample size. Even in the previous case, I said, there are only 30 patients. There are only 30 patients available during the last 20 years. So You have to justify that this is the scenario. I'm going to study using that 30 participants, and even if I calculate a sample size, it may come as 60 or 70 or 120, but that is not possible for us. And we are covering everybody. We are taking everybody. So the justification is important. And most often when students write their sample size justification or that sample size part, what is lacking is that they are not telling the whole story. Okay. So they are only sometimes, tell this is the sample size calculated, or these are the basic assumptions and all. But, if especially when we are dealing with such a scenario where a direct formula is not practically useful and all, there we have to narrate the details and explain it and justify, and so that the reviewers can understand the scenario, and of course there will not be any issue, then they will not raise any issue. That is what my uh, uh, that is what I am thinking. Okay. And of course, the question is like, when reviewers are asking you have to rethink about the sample size, there also one important thing that the researcher may not have adequate thinking about sample size. Most often that also comes. Okay. So they may not have a proper understanding of the context, and they did not think about that properly. Okay. So it is always important to have some consultations with some experts when you deal with this part. Okay. Now, sampling strategies again. I said when you say sampling, which means that you have a target population and you are picking a representative set of individuals or patients from that target population. But practically speaking, most often, especially in clinical research, such as sampling process may be very difficult to, perform. Okay. And I'm not going to discuss about all these sampling strategies, but briefly telling you that there are probability sampling, or that is called the random sampling, or non-probability sampling. Okay. Or non-random sampling. So like conveniently we are taking sample, purposive sampling, purposively. Okay. We are taking a sample, or we are selecting one individual just thinking based on some specific characteristics or judgment. Okay. And snowball sampling again is a non-probability sampling, but sometimes it will be very useful, or there is no other way to identify a sample of subjects. So we will identify some certain individual first, and then through them we will identify other people, and through them we will identify others. So like a chain, and we will stop the process at when we have the adequate size for your study. But then quota sampling also is there. Maybe probably next time the sampling can have another session, sir. Then I can explain more about that. But the point is that when you have an opportunity for doing a probability sampling or a random sampling is possible, then you go on with such a sampling that can ensure you a more representative sample that will give you a more generalizable result. Or when you say this is what happening in this particular group of patients, it should have more reliability. Okay. And the other way around, sometimes there is not at all possible to apply a sampling, random sampling strategy, then you may go on with that. Okay. So anyhow, when we have your proposal, you have to think about the possibilities. You have to think about the possibilities. Okay. And doable, whether it is doable or not doable. Okay. If it is not at all doable, then you go on with the non-probability sampling, and we should have adequate justification. So we have to provide the justifications and explanations for what is a suitable sampling strategy, and why I adopted this kind of, or why I am suggesting this sampling strategy. Okay. And of course, this probability versus non-probability sampling can address a lot of bias, especially like selection bias. Okay. And we can also think about the information bias. See, when you collect your data, that data should be uh, reliable. That data should be should keep good quality. A good quality data, a good quality data only can provide good result. Okay, so we have to minimize all these things. Another statistical thinking comes when when you plan your study is like whether when you try to explore the relationship between variables, and you have to think about any other potential confounding is happening there. Okay, whether it will influence my result. And finally, when you complete your study, because of these confounding, you cannot actually produce the results with the good evidence. So whether that is a possibility, or you have to think about what I can do, whether I can do anything to avoid the confounding at the design phase itself. Let me just check the timing, sir. It's, I think I.
Dr. Jissa, can you
To
just
wind up.
complete?
Yeah, I
To
can.
wind up.
I'm sorry, sir. Always. Okay, so I am going to stop now. So then you have to think about data management and analysis. Okay, already I said everything is connected. Everything is connected. Okay. And while writing the proposal itself, you have to think about how the data will be entered, whether how the variables will be coded, okay, how the missing values will be handled, etc. And common mistakes, many common mistakes we do usually are like, when the proposal is initially submitted, the research question is very vague, okay, or the objectives are very vague in terms of picking up the study population or the outcome of interest and what are actually you are doing. So that is very important, and the rest of the things we already have discussed. Okay, and so this is the statistical planning or the statistical thinking, then the needed statistical thinking while you plan your research. Okay, and yeah, so the summary is like statistics starts with the research question, and we have to plan, uh, design, we have to plan the design, sampling and sample size, all these things early. Also, you have to plan what kind of analysis you will be doing. Okay. And it is very important that to understand that we should not think about what statistics I will apply after your data. You should have a prior thinking about what statistics I may apply at the end of my research. Right. So the take-home message is that collecting data without statistical planning is like constructing a building without a blueprint. The purely analyzed data can be reanalyzed. Okay, but a poorly designed study, we cannot retrieve. Okay, we cannot retrieve back that data. So that is my. So I'm stopping at this point, sir. Sorry, I just took another 10 minutes additional. Yeah.
Thank you, Dr. Jissa. It was a very educative talk, but unfortunately, because we have multiple programs, I don't
Yes,
think we have time to discuss this. So we'll again call you in another time for another talk on this thing. So,
yes.
so because we're running short of time, we'll now go to the next program. Thank
Yeah,
you.
yeah, yeah, I know.
Thank you.
I didn't check the timing in
Okay,
between.
no problem. Thank you very much. Listen, actually, it is a
Thank you.
very educative talk. Thank you.
Thank you, sir. Thank you, sir. And I'm always happy to be part of such discussions, and we can convey the perspectives of statisticians in research. We can communicate it with other research. That is
Let's
all.
start with the case.
Okay, thank you so much. Thank you. Now we will go to the next part of the program, that is a case presentation. I would like to invite Dr.
Rajeshwari.
Rajeshwari from JIPMA, senior resident from JIPMA, to present the case. And as usual, we have a galaxy of distinguished faculty, Dr. Jagan Mohan Taragan, the professor and head of the Department of Cardiology at Sri Chitra, Dr. Sudhir Kumar, former professor and head of the Department of Cardiology at Medical College, Kottayam. Then we have Ajay Mahajan, who is a professor and head of the Department of Cardiology at KEM Medical College, Bombay, and Dr. Santosh Satish, professor of cardiology at JIPMER. The case will be presented by Dr. Rajeshwari, and the student panel is from KEM. Dr. Aditya, Dr. Praveen Panwar, and Pooja Lal. May I invite the examiners to take over and invite the presenter to present the case. Over to the examiners.
I think we can get started.
Yeah. Rajeshwari, can you present the case?
The case can be presented, and after your presentation, the KM candidates or presidents can summarize and give their interpretation. Okay.
Time factor, Dr. Time
Yeah.
should be up to 8 to
Be
15.
brief so that we don't have much time. It's not a long case.
Yeah.
I think by time it's a very short case.
So I think
Yeah.
you can go
Get ahead.
8:15, 8:20.
Yes.
Okay.
Good evening, everyone. Today I'll be presenting the clinical case of a 22-year-old male. He hailing from Kallakurichi, studied till 8th standard. He's unmarried, Hindu by religion, low socioeconomic status, and informant is the aunt and the patient himself. So he presented with chief complaints of exertional dyspnea from the age of 10 years, exertional giddiness and palpitation since 14 years of age, and recent recurrent pre-syncopal episodes during exertion, that is in the past month. History of present illness. He was noted to have a bluish discoloration of skin and lips since 3 months of age. During infancy, aunt noticed excessive cry during feeding associated with chest retractions. He was evaluated for the same and diagnosed to have congenital heart disease at 3 months of age. There was no history of recurrent lower respiratory tract infections, no history of cyanotic spells or squatting episodes. From the post this was the infancy period. He was entirely asymptomatic till the age of 10 years. Then from the age of 10, he noticed breathlessness on playing, running, climbing 2 flights of stairs corresponding to NYHA function class 2. He could not keep pace with the peer age group and was unable to participate in competitive school sports due to easy fatigability and breathlessness. This dyspnea is static, and currently also the patient is still in functional class 2. There was no associated orthopnea, no PND. There was no cough with expectoration or hemoptysis, and there was no seasonal variation to the breathlessness. From the age of 14 years, he developed episodes of giddiness, primarily occurring on exertion, lasting few minutes, not associated with loss of consciousness, no tongue bite, no urinary or fecal incontinence, no postictal confusion, which the giddiness episodes relieves on stopping activity on taking rest, and there is no diurnal variation or no relation to the posture for this giddiness. Then he noticed palpitations, same again brought on by exertion, sudden onset, regular rapid, lasting few minutes, not associated with neck pulsations or post palpitation diuresis, and the palpitations relieves on taking rest. There was never any history of angina on exertion. So this was from the age of 14 years. These symptoms were static. Now recently in the past month, he has frequent pre-syncopal episodes, that were 5 in the past month, occurring on exertion, not at rest. They were gradual onset with a prodrome of lightheadedness and blurring of vision, last few minutes, relieved by stopping activity and rest, but there was never any loss of consciousness or never loss of postural tone. So there was no syncope. He also gave a history of headache for the past 20 days, which was holocranial, constant, dull aching type. It was not associated fever, nausea, vomiting, neurological deficit, slurring of speech or convergence, and it relieves on taking over-the-counter analgesics. No blurring of vision or other visual disturbances, no tinnitus, paresthesias, numbness or tingling of fingers and toes, no myalgias or muscle weakness. There was no history of joint pains, epistaxis, gum bleeding or easy bruising, no facial puffiness or pedal edema, no abdominal distension or pain in the right hypochondrium, no complaints of decreased urine output. There was never any history of prolonged fever in the past, no unexplained weight loss, no night sweats, no skin lesions, no history of focal neurological deficits or altered sensorium. There was never hemoptysis episode till now or pleuritic chest pain. Past history, there was no history of recurrent sore throat or migratory polyarthritis symptoms, no history of prior cardiac surgery or catheter-based intervention. He's never been on any medication till now. no comorbidities like diabetes, hypertension, no past history of TB or bronchial asthma. So he was a second born of non-consanguineous marriage. That was a term delivery at local PHC. He was like aunt remembers that he had low birth weight, but there was never any NICU admission or referral, and no developmental.
There is nothing relevant. I think you can, because running short of time,
Yes.
there is nothing relevant. So you can summarize the history.
Okay. Personal history is not. So
okay, fine.
So summarizing the history, this is a 22-year-old male with cyanosis detected since 3 months of age, with heart failure equivalent symptoms in infancy, followed by development of exertional dyspnea of function class 2 from the 10 years of age, which has remained static till now, and exertional giddiness and palpitations from 14 years of age, with recent onset presyncopal episodes and headache, likely hyperviscosity symptoms, with no features of infective endocarditis or acute rheumatic fever, and no significant family history or no syndromic features.
Yeah, I think we can ask the KEM people to interpret. I'm sure they must have had this with them for about half an hour. So,
But
KEM,
before that, I want
one of you can just tell us what do you think from the history, because after the history is going to give you some idea about the functional status, some idea about the etiology, some idea about the complications related to the heart disease, or any systemic illness which is the heart disease a part of it, isn't it? 3 or 4 things you are looking for from the history. So what are the interpretations that you have from these 4 aspects?
Shall I intervene
class,
a little?
Possible etiology, complications. Yes.
Shall I intervene a little bit, because I want to give some comments about this, because certain things you have to modify in your presentation, because a little bit of training also. When there is only history of exertional giddiness, then you need not talk about all the other things like involuntary, all those things. Only if there is loss of consciousness. That was a too much stretching. Second, heart failure equivalent symptoms. I think I may ask you questions on that. What do you mean by heart failure equivalent symptom? Because I'm not tuned to that type. What was the heart failure equivalent symptom? I will ask you 1 or 2 questions. You can modify the history. Past history also you have to modify, because you have started from 3 months of age. So there is nothing put past history like that. You can avoid that subtitles. Okay. But what do you mean by this heart failure equivalent symptom in this patient? What was the heart failure equivalent symptom in this patient? I seldom use that term, heart failure equivalent symptom. Well, that's a very important thing. That's a very important thing, which I think the other team will be discussing. So what was in your mind when you said heart failure equivalent symptom? What is a recurrent respiratory infection?
Recurrent respiratory infection is one, sir, but that was not there.
That's all the thing which you have said in your history. But it doesn't mean it is heart failure equivalent, because many times it is due to so many other things, because pediatrics, we see this as a common thing. Okay, the discussion team, Praveen et al.
So seeing the history of a cyanotic congenital heart disease, with the onset of cyanosis at 3 months of age.
Not clear. Can be a little louder.
Sir, am I audible?
Yes.
Audible, but
please speak loudly.
Loud.
So, sir, we have a 22-year-old male with history of a likely cyanotic congenital heart disease with the onset of cyanosis at 3 months of age.
Okay. Yes. Next.
The possibility, since he has progressed well into adulthood, and with the symptoms fluctuating over the years, I would like to keep a possibility of tetralogy, top physiology for this particular case.
You mean PS rather than PAH, right?
VSD with PS.
Those 4 or 5 questions. You said cyanotic, obviously cyanotic. Whether it is increased pulmonary blood flow, decreased pulmonary blood flow, whether there is PS or PAH, and whether it's an LV dominant or RV dominant, which will not be coming out from the history, isn't it? From these 3, 4, cyanotic, you said, obviously. Whether PS or PAH, what is your option and why?
Sir, no pulmonary hypertension, sir. Likely to be with pulmonary stenosis.
Why do you say that? Because she has put heart failure equivalent symptom with no cyanosis, spells, and squatting. So could you make an assessment that it is a high pulmonary blood flow or low pulmonary blood flow from this history? And the second thing, the natural history, is it, are the symptoms, do they favor the usual presentation of a tetralogy like physiology? That's the oddity. So we may have to clarify, because she has put it like this: heart failure equivalent symptoms. And she said no spells, no squatting, all those things. So that's only oddity in that. Okay, go ahead. So let us say it is a pulmonary stenosis group. Then how will you proceed?
No, I don't think we need to presume it is pulmonary stenosis. It can be decreased pulmonary blood flow, okay. Or is it increased pulmonary blood flow, according to you, currently? Maybe at the age of 3 years, heart failure may give you a feeling that it was increased pulmonary blood flow going on to some heart failure, some breathing difficulty and all that. But currently, what do you think it is? Decreased pulmonary blood flow or increased pulmonary blood flow? And what are the reasons if you suspect it is increased? What are the etiological factors which you think it is decreased pulmonary blood flow?
Increased only, sir.
So there the useful thing will be
let them reply.
Yes, sir, likely increased pulmonary blood flow. Not
Do you think the patient just even now has increased pulmonary blood flow?
Yes, sir.
With recurrent syncopes and all those things, you still think of increased pulmonary blood flow at present? So what is the natural history of increased pulmonary blood flow with cyanosis? They tend to become?
What is the pulmonary physiology now? Is it if it is increased pulmonary blood flow, what has happened by this age group? So that's the thing which you have to look into.
Effort near syncope.
Pulmonary hypertension, sir. Pulmonary hypertension has developed.
Yeah, pulmonary vascular disease and pulmonary artery hypertension, right? So these are the reasons why this patient can have these symptoms, isn't it? Yes. Because we have not got any clear evidence of congestive heart failure. There's no orthopneas, no PNDs. There isn't any pedal edema or hepatomegaly symptoms or what patient may feel as elevated venous pressures. Nothing is there. So then obviously you should keep in mind whether this patient is going into pulmonary artery hypertension or it's pulmonary stenosis. An increased pulmonary blood flow at the age of 3 months can have natural history of 2 ways, isn't it? It can develop pulmonary stenosis or increased pulmonary blood flow going on to pulmonary hypertension, reduced pulmonary blood flow. So what do you think amongst this? Gassol's VSD, they are initially a little heart failure. Soon the pulmonary outflow becomes stenotic and they become like tetralogy fallow.
So here I just want to interrupt. So the most important catch in this particular patient is the cyanosis at the age of 3 months.
That's correct.
So what is the condition when there is a cyanosis at the age of 3 months and then there is no cyanosis? So cyanosis, no cyanosis and reappearance of cyanosis because of pulmonary vascular obliterative disease. So
no,
which
I
are
don't
the
think there
conditions?
was a point at any time where the patient had no cyanosis. Did you say that? And as cyanosis occurred, I thought cyanosis was there from birth and it's continuing, and from 3 months and it's continuing. That's what is the history was suggesting.
Was there from birth and it is continuing.
Okay.
No. See, a biphasic form of cyanosis, there are very few conditions. Can you tell us a child who is early cyanosis and then cyanosis disappears and then reappears? There are very few conditions.
Epstein's.
Yes, it's a classical Epstein. Can you just tell us why? In two lines, why Epstein's has this classical biphasic response? Really, no other condition has this classical biphasic response.
So, yes. Due to very high neonatal PVR, so till the point of reduction, normalization of the PVR, there is right to left shunt across the AS.
Very good. That's correct. It's a reduction of the pulmonary vascular resistance as the child, in infants. The tetralogy, since becomes less right to left shunt, it becomes either left to right or some small right to left. That's right. So that's the reason. No other condition really has this biphasic in the natural history, unless they are complicated with something else. Okay. So we have, of course, only PS or PAH and decreased pulmonary blood flow, increased pulmonary blood flow. Obviously, I think, I don't know if discussion has gone into more of decreased pulmonary blood flow. Now, whether it's PS or PAH, of course, you can take a call on that. I would obviously think of PAH, but certainly PS is an option. So shall we?
I think one of the things which you have to consider in this case is initial history was not favoring either of these things. Well, there was nothing strong to suggest a high flow or a oligemic group. But then the natural history will be very useful. If you look in the natural history of a tetralogy of fallow, what are the symptoms they are likely to develop? Usually these are not the set of symptoms that they develop. This set of symptoms like exertional fatigue, exertional syncope or pre-syncope, it's more often with a pulmonary hypertensive group rather than an oligemic group. Oligemic group continues to have exertional breathlessness. They are relatively more preserved unless they develop some other complication. So that is a thing which you have to think. Second thing, there was a clue in that which she gave heart failure equivalent symptom. So she knew the diagnosis. So
I think we will not discuss that heart failure equal. Actually, this patient has been having dyspnea for the last 10, 12 years. It has not progressed. So I don't think really there is a component of heart failure. Is it not?
Yeah, that's the point which we want to know.
The patient has been stable for 12 years with symptoms of dyspnea, the same class, and NYHA class. There are very few etiological factors of heart failure that I can think of. I don't think at this point in time this patient has heart.
Yeah.
Now, so this equivalent, I have no idea about this equivalent. It may be a new term coined for convenience, but I don't think it has to be discussed.
The point is, in this case, initial history is not contributing to either because there can be limitations in the history. The early history, there may be limitation, we may not. But when it is difficult, you take the natural history of the symptoms and the findings. Naturally of the symptoms, usually when you get exertional fatigue, exertional graying of vision, near syncope, all those things, then that will probably favor a development of pulmonary arterial hypertension or pulmonary hypertension. In this case, there is the stage group 1 pulmonary hypertension. So you have to think like that. This is a cyanosis which occurred quite early, relatively early. 3 months means it might have been there still early. Because if the parents have detected cyanosis by 3 months, most likely the desaturation might have been there quite early also. Early development of pulmonary cyanosis and a natural history which the patient is becoming more symptomatic in the second decade. In tetralogy of Fallot, they continue to remain like that. Okay, maybe having mild reduction of effort, still the symptom will be the same. So that may be too close to say that this may not be the typical tetralogy of Fallot equivalence. It may be more of a complex lesion progressing to pulmonary arterial hypertension. We know that Eisenmenger, there are so many cyanotic conditions. So Eisenmenger means, or the group 1 pulmonary hypertension means, they are basically a pulmonary hypertension plethoric group where they develop PH. It could be cyanotic or acyanotic. That could be the first possibility as I am concerned.
Second, that's right. I think that's a good question. You should ask them. No, 3 months old cyanotic. What are the conditions which can be as Eisenmenger now? What are the conditions which come to your mind? We say it's an Eisenmenger, but cyanotic at 3 months. What are the conditions? I think Jipper, you can tell.
Admixture lesions with increased QP situation. So all the admixture without PS, like single ventricle, no PS, DORV subpulmonary VST without PS, or TAPVC, truncus, like based on the survival order.
Good. That's correct. Now, I just wanted to tell the people that don't think of only left-right trends going on cyanotic and Eisenmenger. Eisenmenger only means increased pulmonary blood flow decreasing to systemic level. That means the systemic blood flow becomes more than, or pulmonary blood becomes less than systemic blood flow with a PVR of more than 10. That is Eisenmenger syndrome. Cyanosis is not a part of your Eisenmenger syndrome definition. Okay? Yeah. Good. I just wanted to bring that point. Next,
Madam, if you tell TAPVC, there will be some question because TAPVC doesn't, the usual type doesn't survive up to this age group with minimal symptoms like that. Yeah. If they are going to develop Eisenmenger, which is not that common, then it could be different subsets where the patient will be much, much more symptomatic. But otherwise, I agree with you. So this next point which Dr. Jagannath said is Eisenmenger doesn't mean a left-right shunt progressing to right-left shunt. It is development of irreversible pulmonary vascular disease. Basically, a high flow group with left-right shunt or bidirectional shunt. Okay, that's it. Okay, fine. Shall we go to the physical findings then?
Let's go to the findings. Quick.
Coming to the general examination, he was conscious, cooperative, well-oriented, time-placed person. He was thin-built and undernourished with a BMI of 19. There were no dysmorphic facial features, no skeletal abnormalities. There was uniform central cyanosis, which was noted, and grade 3 pandigital clubbing. No paler icterus, lymphadenopathy, and pedal edema. No peripheral signs of infective endocarditis or aortic regurgitation. JVP was 4 centimeters above the sternal angle in sitting position with a prominent A wave.
Just a minute. 4 centimeters above the sternal angle with prominent A wave may not be an acceptable thing. Always now mention root of the clavicle. And if you are seeing the JVP or only the AV, because if it is 4 centimeters, it may not be easily visible.
Oh, the sternal angle in
have you
sitting
seen?
position.
Only the A wave is
It's only that you can see the prominent A wave. You are seeing an
it's
A
a
wave
mistake.
only,
Let
or
me
are
tell you
seeing...
one thing. You cannot say JVP seen 4 centimeters above the sternal angle in sitting position. In sitting position, the JVP cannot be seen unless it is more than 6. That is the distance between the sternal angle and the clavicle in sitting position. So don't make these errors. Don't just routinely write some things. Right? If you're seeing the A waves, okay, right. So certainly mean JVP is not elevated, and there is probably a prominent A wave. Okay, you understand what I'm trying to tell you. Many times the examiners are very unhappy when you write things which are inconsistent. Okay, let's go to the next.
So the point is same. That is, are you seeing only the prominent AV? It may,
Yes.
with your finding, I also infer that you may be seeing only the AV.
Okay. It was only the prominent AV.
If it is 4 centimeter from the sternal angle, then the AV is not prominent, because normal height of AV also comes only up to that level. So be careful, because you may face so many questions. 4 centimeter from the sternal angles means it is probably 9 or 10 centimeters. Normal AV height can go up to 11 millimeters mercury. Okay, fine.
Pulse was 83 beats per minute, regular rhythm, normal volume and character, no radio-radial or radiofemoral delay. All the peripheral pulses were palpable and equal in volume in all the 4 limbs. Blood pressure was 160 in bilateral upper limbs, and it was 110 systolic in the left lower limb. Respiratory rate was 22 cycles per minute, regular abdominothoracic type of respiration. Saturation on room air was 75%, and he was afebrile to touch. Coming to inspection, chest was bilaterally symmetrical. There was no precordial bulge, retraction, kyphosis or scoliosis, no accessory muscle use of respiration. Apical impulse was seen in the left fifth intercostal space in the mid-clavicular line. There was a visible pulsation over the left second intercostal space just lateral to the sternum. There were no epigastric, suprasternal or other ectopic pulsations like left third intercostal space pulsations or right sternoclavicular pulsations. There was no scarce sinuses or dilated veins.
Okay, now 1 minute. Just so, what is your interpretation of these inspection findings? Very brief.
There was no prominent precordial bulge.
No cardiomegaly, no precordial bulge, and
no cardiomegaly, no precordial bulge,
visible pulsation in the second left intercostal space. Means what?
So pulmonary artery pulsations, like
okay.
dilated.
Right. So now we go to the palpation and see whether it is a prominent pulsation or just visible pulsation. Okay, next.
So apex beat was confirmed.
What you can do is at your level, inspection and palpation you combine. You need not be too stretchy. That is, there are no chest deformities. You need not be stretch. You need not stretch too much in your presentation.
Especially short cases,
no chest
very, very
dilated
precise.
veins. The apex beat is seen and felt. We will combine that, because we want to get an idea of the anatomy and to some extent the PA physiology. What is the cardiac size? Is it LV, RV? Then what is the PA like? What is the relation of the great vessels, if possible? So inspection palpation should give us an information about the cardiac size clear, but LV dominance, RV dominance, biventricular dominance, pulmonary artery hemodynamics, is it hyperensive or not, low hypotensive? Then, if possible, an idea about the great artery relation and situs. These are things which you have to get before your auscultation, because then you target your auscultation based on this. So you can just make it very brief. Okay.
Yes.
Palpation.
Palpation, apex beat was confirmed to be in the left fifth intercostal space in the mid-clavicular line. There was medial retractions noted. It was a localized apex. P2 was palpable. No other heart sounds or added sounds which were palpable. No parasternal heel. Left second space pulsations were palpable, the same one which was seen in the inspection. No epigastric or right sternoclavicular pulsations. No thrill over the precordium, axilla or back, and no liver pulsations.
So now you have to answer my questions. That's the way. Because auscultation doesn't help you much. So now your auscultation or your findings, you got some idea about that. What is the conclusion you have drawn from this finding based on our initial discussion?
So P2 is palpable, sir.
So what do you think?
So
P2 is palpable. There are pulsation in the second left intercostal space and second zone is palpable. You should be extremely careful. Is
So,
it the second space closer to the sternum or little away from the sternum? Because there are two causes which can produce this. What are these two causes? One is
second
simply
space,
dilated pulmonary artery with pulmonary hypertension or a malpose diuta with palpable or loud A2. So that's important. So the base examination, it's extremely important to see what is contributing to that. That will sort out the whole thing as far as the physiology is concerned. Anatomy may be a little difficult now. Okay.
yes. So the left second space pulsations very closer to the sternum, so likely dilated PA, and there's a palpable P2, so PH is there. But there was no parasternal heave, that is important here. And coming to percussion, right border of the heart is behind the sternum, left border of the heart corresponds to the apex, left second intercostal space was dull, and the upper border of the liver dullness was noted in the right fifth intercostal space in the midclavicular line.
So
Coming
in percussion, you have to talk situs
Yeah,
solitus.
go ahead.
Okay, that's what you have to tell. That's the most important thing in this. The only additional information we want is situs. You can straight away
on the
say
side.
situs is solitus. Okay, auscultation.
S1 is normal. S2 was single. It was allowed P2. LV S4 was present towards the apex. There was no
You should be
S.
extremely careful when you say LVS4. Okay, you should be extremely careful when you say LVS4 in such a situation. Okay, go ahead.
There was a high frequency early systolic click, which was heard at the left second intercostal space, which was non-phasic, likely pulmonary ejection click. And there was a soft early systolic murmur of ejection type, grade 2/3, at the left third intercostal space, which was crescendo decrescendo with a very early peak. It was a very early peaking murmur, and there was no radiation to this murmur. And there was an additional murmur noted, which was high pitched, short blowing decrescendo, early diastolic murmur heard at the left second intercostal space with no change with respiration, and there was no systolic murmur at the apex.
Dr. Praveen et al., why don't you discuss to the discussion of the findings to arrive at a possible hemodynamic diagnosis, then coming to the anatomical diagnosis.
It shows left second intercostal space as
Loud.
It shows left second intercostal space as pulmonary ejection click. So it goes more towards your
Your interpretation. Don't repeat those findings. Interpretations on this finding.
more of PS, pulmonary stenosis.
Pardon?
Pulmonary stenosis, PS.
Pulmonary stenosis.
Oh my, I think that will be a little
No,
difficult.
this is a patient with dilated pulmonary artery, palpable S2, and an early diastolic murmur, most likely pulmonary agitation. That I think.
They are putting everything to you to tell it is PH, and then you are. Please be careful. Don't be too casual, right?
So that was the point in this. Palpable, it is pulmonary hypertension supported by the pulmonary, she said pulmonary ejection click or a constant ejection click, and an EDM, most likely pulmonary regurgitation because the pulse pressure is normal. So there is severe pulmonary hypertension with pulmonary regurgitation and right to left shunt. Okay, so physiologically or hemodynamically it is equivalent to, because the patient is symptomatic, it is equivalent to Eisenmenger syndrome.
We are giving you the clue, isn't it? That it is likely to be a Eisenmenger syndrome, right? Okay, with severe PAH and hypertensive pulmonary regurgitation. That's a Gram-Smith murmur that's being discussed. There is not much of cardiomegaly. There is no cardiomegaly. Palpable pulmonary arteries, single second sound, constant ejection click, a very non-specific or in very short systolic murmur just for namesake, but clear early diastolic murmur. So what are the things which come to your mind?
The only question you are likely to face to madam is fourth sound. That's a little odd thing.
Yeah, I think we could just leave it for the time being because...
No, I just want to tell that fourth sound, you should be extremely careful.
That's right. If it doesn't help you much, don't unnecessarily put in physical findings which you may not be able to, which might, sort of redirect the discussion elsewhere. Yeah, yes.
So now what are the possibilities?
So the possibilities, we have given you the findings. We don't know the diagnosis, but we have given you the important findings on which you can build up. Okay, then I think I'll have to ask Dr. Rajeshwari, what are the things you thought of? 1, 2, 3, 4, without being biased by the final diagnosis.
So there was a clear-cut evidence of severe pulmonary artery hypertension. So because there was a loud P2, like it was almost
So
banging.
that was said. What are the possibilities? Unless you differ from what we discussed as severe pulmonary hypertension, pulmonary vascular disease, pulmonary regurgitation with no cardiomegaly, single second sound. You agree with these findings?
Yes, sir. With no cardiomegaly.
So tell us the possibilities.
Single second sound, but on the
No, that's okay. That's okay. Now, sir is asking what could be the anatomical thing. Could you get
these findings,
some
what are the
idea about
possibilities you would have thought of?
anatomical things?
So I
Structure.
initially thought it was a single ventricle with an LV dominant physiology because there was no parasternal heave, no like subcostal pulsations, and this with so much pH, there is no parasternal heave at all. So I thought like single ventricle with a LV dominant physiology.
No, what would be the? I would just want to tell you one thing. What would all be think would be the problems against a single ventricle in this case? What would be the findings against it?
Findings.
What is the position of aorta in large majority of single ventricles?
So majority of
the LV type?
In the LV type, it is a malpose great artery.
L malpose aorta. That's what Professor Sudhir was trying to tell you. If you have the same pulsations also in the third space, you should be very careful. A single second sound, a palpable pulmonary artery, arterial pulsation in the third space, think of L malposition of the aorta, right?
Basically, you know that this is a normally related great artery the moment you picked up the main pulmonary artery pulsation. So normal great artery relation.
Which is unlikely in a single ventricle,
you said that now the ventricle is the important thing. Okay. The ventricular arterial relation. Ventricle is the important thing. Could you get some idea about the ventricle? You said there is a retraction.
Medial retraction.
Be careful when you talk about the apex, all those things. Okay, fine. Go ahead.
Anyway, I know your S4 and your medial retraction and all were pointing towards single ventricle, which of course it may be possible at the age of 22, a single ventricle with severe pulmonary hypertension, because that's no problem. That's not an issue. Only thing is they become inoperable by the age of 3 months. That's the only thing. They can survive probably, but it will be one of the rare cases. But because of your findings, we are also wondering why you said, but you didn't talk about LV apex. You only said apex is localized, but there is medial retraction and there is no parasternal lift. So we knew that there was something like a left ventricle which is dominant. Okay. So any other possibilities with these findings?
A second possibility will be tricuspid atresia with a normally related great arteries.
Tricuspid atresia, normally related great arteries, and PAH, huh?
With PH, with no PS physiology, like leading to Eisenmenger.
All right.
But if it was not Eisenmenger, what could have been the findings if it's a tricuspid atresia without pulmonary stenosis and a large VSD? We are going for rare things. Okay, we are going for rare things. The question again, left ventricle. Okay, we have discussed a single ventricle. I don't want to stretch that discussion. So basically, because you are not sure about the ventricles, very soft finding of the medial retraction, it may be extremely difficult. It may be, you can say it is not. It is a situation where the vessels are normally related. So the transposition or malpositions we have to take away. So this is a situation where there is a cardiac anatomical defect with large ventricular septal defect or good communication, and a pulmonary artery which is normally related anterior and to the left. So certain things like transposition is out, LTJ is less likely. The usual type of single ventricle with abnormal malposed great arteries are unlikely. So you have to think of other conditions. That's all what I want, because it may be extremely difficult.
After all, this is a clinical diagnosis. We are not expecting accurate diagnosis. Let me tell you one thing. Accurate diagnosis is a drawback in clinical discussion. You have to think of the most likely things. I have never seen a single ventricle with severe pulmonary hypertension at the age of 22. I have probably not seen a tricuspid atresia, normally related vessels with severe pulmonary hypertension. So usually they tend to have a VSD which over time it becomes smaller and becomes like PH. I have also not seen at the age of 2. So this must be a very, very rare case. But then there are more common cases that we have seen, like a DORB with a VSD.
What about DORB with a VSD?
Most likely,
why do you think of a DORB with
DORB, we have to consider this.
or like a classic Bing type?
DORV will usually have either predominant right ventricular hypertrophy or a biventricular, but here there is no.
No. The problem is
there is a
person
large
Jagannath
VST,
is-
so you are not going to be able to appreciate. A large VST basically means that the right ventricle or anterior ventricle is never suprasystemic. It is suprasystemic or volume overload, which gives you the parasternal lift very significantly. That Eisenmenger VSTs generally may not even give you any parasternal. So there's a large VST. RV pressure is never systemic, and it doesn't. It actually empties into the aorta without any obstruction. So there is neither obstruction nor volume overload, and pressure is only at around maybe systemic level. So that again tells you that you should think of these two things.
Basically, I thought
generally, URV with subaortic VST may not be cyanotic at the age of 3 months. They behave more like a VST.
Toxic being could be the point.
Unless you do a pulse oximetry. I don't think 20 years ago pulse oximetry was possible. They would have to do a blood gas or something like that, or obvious cyanosis. So then maybe DORB with that double outlet diagonal with subpulmonary VST is another possibility. TJ is unlikely, but still anything can survive at this age.
But the pulmonary artery, okay.
Yeah.
But basically, I think we need not go into the finer DD. Basically, what we have is a cyanotic with severe pulmonary hypertension, normally related great arteries.
Yeah.
Then the anatomical thing, certain things with normally related great arteries, we can say low in the list, like transfusion, LTJ, single ventricle. Then talking about other things also, it is extremely difficult. So you can say that the rest of the things I would like to sort out by ECG, X-ray, all those things. That's all what we want.
We are spending on time. Let's go to some more interesting things like echo, ECG. All very short now. We are short of time. I think Venu is already
10 minutes.
I will consider, in this case, I will consider DORV subpulmonary VSD as a first differential diagnosis.
Yeah.
Okay.
We could be wrong, but
as an examiner, I may not be very keen to see what is the underlying disease, but we will go to the ECG, X-ray, and echocardiogram in a short time.
So
with the radiology, X-ray may not be very helpful. With your findings are right, the radiology may not be very helpful. So ECG may be more informative because we have cardiac size, main pulmonary artery is dilated, and vessels are normally related. So
let's see
I am
the
not
ECG.
sure.
Let's see the ECG.
So this is a 12 lead
Very
ECG
good.
with normal standardization. Showing sinus rhythm with a heart rate of around 70 beats per minute.
How does this ECG help you in our diagnosis? Because all the other things you should read. Now this electrocardiogram favors which diagnosis?
So based on two things, like one is axis and one is which ventricular hypertrophy. Here it's clear-cut left axis deviation with an axis of around minus 75 degrees.
Yes, go ahead. LVH, LV dominance, LVH with the LV dominance with the left axis deviation. Which are the conditions which can have this with normally related great arteries?
So
the first thing,
tricuspid atresia with normally related great arteries.
Okay. Yeah, you are right, actually. So we give you all the credit for having come to the correct diagnosis clinically. I agree with you. With this extreme left ventricular dominance, no right ventricular forces at all, and leftward axis, tricuspid atresia with pulmonary hypertension is, of course, the first diagnosis. Once in a while, you will get. Let me just complete. Once in a while, at DORV with subaortic VST, also you may get extreme left axis, but generally they give you some right ventricular forces. But here, right ventricular forces is 0, so right ventricle is probably absent. Okay. I think that's good enough. I don't think we need more discussion on this.
There is a little oddity for this thing because at this level to have that much of LV voltages is a little unusual when they go in for pulmonary hypertension. So we have to think whether
still there are good Q waves.
Even now,
Q waves in V5, V6. What does it tell you?
Like
Q waves in V5, V6.
LV forces, some volume overload is still there.
No, it is intact septum. So it is not a single ventricle. With this ECG, you will not consider single ventricle. Right? The classical single ventricles. Here it is a single ventricle of the tricuspid atresia type, where the ventricular septum is formed. So this has to be a septum which is well formed. So it can't be a single. Good. Next, let's go to the. All right, this I think is fair enough.
So this is a chest X-ray PA view. Like adequate exposure and good.
Does it contribute to, that's a way running short of time, does it contribute to our further discussion?
No
Is it
cardiomegaly.
consistent?
No
Okay.
cardiomegaly. No right atrial enlargement. LV type of apex.
But do you think this is isomer X-ray?
No,
That's the
this is
question which I would like to ask.
so
that's
this.
the point. That's the point in this case. Limitations. We have very good LV forces. Very good LV forces mean there should be volume coming to the left ventricle. So the pulmonary vascular disease may not be severe. So even in tricuspid atresia, when they go in for an isomer like this is not common, then you are not expecting that much of LV forces, LV volume or more. So at that point itself, that the isomer or an irreversible pulmonary vascular disease was coming low in the list. The radiology also doesn't favor because you can see the peripheral vessels traceable up to the periphery. Very unimpressive X-ray. So we'll go to the echo, Dr. Jagan.
Yeah.
So this is an echo showing situs and levocardia. This is an apical four-chamber view, which is showing a large ASD, like almost equivalent to a single atrium, and there is a large VSD and a ridge of tissue at the tricuspid location, so no flow across that. So tricuspid atresia with non-restrictive VSD.
Now that you have to reassess to say non-restrictive VSD. You have to have multiple views. That is the.
This is a
shows the pulmonary artery. Just shows the pulmonary artery.
Yes.
Okay.
Okay, fine.
That's the pulmonary artery.
Okay,
Good.
the pulmonary.
Now
you have
normally
to see.
related.
Normally related
I think it will be one of those very rare classical cases which you are lucky to have seen at the age of 22.
How the blood is coming to the pulmonary artery, this large pulmonary artery. From the left ventricle, it is going straight to the aorta, and now you have to see the size. So restrictive VSD, you should be careful when you have that much of pulmonary blood flow. Okay, don't jump to a diagnosis of restrictive VSD on a single frame. Okay.
I don't think it's a restrictive VSD. I don't think so.
Non-restrictive, sir. Large non-restrictive.
Yeah, that's the point.
Non-restrictive. Okay.
He said restrictive. You cannot say restrictive VSD from a single frame.
No, I think
because
she said non-restrictive.
artery is that much dilated. In a patient with tricuspid atresia, you should see from where is it coming. The left ventricle is pumping to the great arteries. So the aorta is normal size. So it should come through a non-restrictive VSD. Okay, fine.
She said non-restrictive, I think.
Okay.
So
fine.
This is the RV outflow from the apical view, which is showing no gradient. So the gradient is only 12. So there is no PS associated.
Obviously.
Okay, good.
And this is a subcostal view again showing the RV outflow, the infundibular portion showing no gradient, no PS.
Good.
Left arch.
Left arch. So what is your final diagnosis? Because we have only 3 minutes now.
So this is a tricuspid atresia, a normally rated great arteries, no PS, with obstructive PH, Eisenmengerized.
No.
Eisenmenger you need not tell now. That is by a cath study where the PVRI is more than 10, isn't it?
Yes.
PVR PVR will be more than 10. So it is certainly pulmonary hypertension. And increased pulmonary, you can't increase pulmonary blood flow as such. Okay, now it's a tricuspid atresia. And saturation is how much?
75.
73. So what do you think will be the pulmonary blood flow compared to the systemic blood flow? I think that's also a good question.
So the QP by QS expected would be 0.8.
Okay. So you are meaning the mixed venous is 60 or 50?
So this so aortic saturation is 75, sir. So like it depends on if it is like admixture physiology, like incomplete mixing versus complete mixing. If we assume it to be a
Here,
complete,
there is no question of mixing. It is a complete mixing. Some streaming. Tricuspid atresia, the books mention rarely there is a non-mixing and streaming. It is generally fairly complete admixture.
Complete mixing with the peripheral oxygen.
All valvular atresias are complete admixture, which is as a rule. So 75 means it
75 with a peripheral oxygen extraction around 20. Then the mixed venous would be 55.
Yeah. Okay, fine. But the point, okay, fine. You can go on calculating.
At best, equal to systemic blood flow or less than systemic blood flow, correct?
Less than.
If it is less than systemic blood flow, it is likely to be Eisenmenger.
Yes.
Okay.
If it is equal to systemic blood flow, the saturation should be somewhere around 85 or.
Correct. But that is only if the systemic venous saturation is 70. 70 plus 15, 85, 85 plus 15, 100. If it is 60, then 80. Okay, I suppose you should read these calculations somehow. Very simple.
You have the
Full
hemodynamic data.
admixture, it's very easy to tell the pulmonary blood flow to systemic blood flow ratio if you know the mixed venous saturation. You have the arterial 75, if mixed venous is 760, as you correctly said, then the QP QS will be less than 1, right? Good. I think we'll finish it off here. And
Do you have the hemodynamic data? Do you have hemodynamics?
We have not done a catheterization study.
Okay,
I
fine.
don't think it
Okay,
is
fine.
necessary really.
Because
Then it
the
is eight.
expected PVRI for a single ventricle would be like too unlikely. With this, it will be too for sending to a Fontaine or this thing. So we have not done a cath.
Yeah, that's
Fontaine, all
correct.
those things will, yeah. Now, the pulmonary arteries are of good size. The pulmonary pressure is likely to be very high. Okay. So you have to keep those in mind when you talk about the rest of the things. Okay. Now, I think it's 8:20. We may have to stop.
Yeah.
Otherwise,
But the last question. What would you have done if this child was seen at the age of 3 to 4 months?
At the age of
So
3
that's
to
the time when you could have salvaged this hypertensive tricuspid atresia.
So 3 to 4 months increased QP for with the heart failure features, PA banding would be the option.
That's correct. You do a PA banding to hopefully make this patient suitable for a single ventricle.
Single ventricle.
There is no question. It's only single ventricle. There's no other option, isn't it? Okay. Thank you.
I think you have done well.
Thanks.
I think we did not give enough opportunity for the discussions because time is very short. That's a problem. I think you have done extremely well. Rajeshwari has done extremely well in this case. But you should not in the straight away discuss about tricuspid atresia when it comes to clinical discussion. You need not come to the real anatomical diagnosis. You can say these are less likely, so I consider rest of the things. That's all what you should say. Don't try to this thing. Now, certain findings like S4, you should avoid because it will be extremely difficult to explain the S4 in this type of cases. And JVP, you have to be a little more careful. Your history presentation, you can make it a little more brief to the point rather than stretching it too much. Okay, good presentation. Keep it up.
Good.
Yeah. I think it is a very excellent case, very rare case to come.
Yeah. I think Jipmer will always see such rare cases. Kerala won't see this because they are all picked up early. In Tamil Nadu, still the health system is to grow. I think that's
one of the DM exam case, whereas the examiner, the candidate has only one diagnosis was tricuspid atresia with pulmonary hypertension. And that it was the case of tricuspid atresia pulmonary hypertension. He did not have any other thing. Our examiners were not very keen to make that diagnosis. That candidate had only tricuspid atresia in his mind. But he was doing extremely well, like Dr. Rajeshwari did. So we won't
I think, doing well in a clinical discussion with a general idea about the diagnosis is not worth it. Let me tell you. That is why we are trying to block you at sort of, give a break to what your discussions and diagnosis are. Please go as though you do not know the case and go only by the physical findings, and all. Okay? This message I would like to give to everybody.
Your approach.
I don't think knowing the diagnosis is an advantage. It may look like a short-term advantage, but in the long term, it would be far more harmful than beneficial.
Yeah. Your approach should be approach to the case, analyze the data, and come to a reasonable hemodynamic evaluation first, and then probably exclude certain things rather than coming straight to the diagnosis in a complex case. Straightforward case, it is not like that. Okay, fine. Okay, Venu.
Okay, I think we'll conclude the session. Thank you so much for that. I think it's a great case. Very, very rare case for the postgraduates. I don't know how many of you from KM has ever seen a case like a tricuspid atresia with pulmonary hypertension. I don't know whether you have come across, but it's a great case.
This is first time for me also.
I have probably not seen one.
This is the second time for me. Because
not having seen one doesn't mean that they were not there, but they were probably intervened much earlier in life.
No, I have seen one in
Kerala today. You won't see many of these patients because they're all intervened well in advance. Some of these neglect cases may come only where health systems have not been so good till recently. Okay.
Okay. Thank you so much. Excellent case and well discussed. Have good participation also. So let me now go to the last part of the program, That is a OSCE which is being presented by Dr. Bhagwati Pant, Assistant Professor of Cardiology, JIPMER, Pondicherry. Is Dr. Pant? Dr. Pant?
Good evening, sir.
Yeah. Okay. Are you audible? We are audible, but have you got
Share
your
your screen.
screen? And Arun, you can tell the rules of the
Yes.
OSCE.
Yeah.
Please tell the rules of the OSCE.
Yeah, Bhagwati, you can take over.
Yes. So we'll have this OSCE session where the rules of OSCE will be like the fastest finger with the maximum correct answer will win, and you should read the question carefully, and you will get a 60-second timer. There will be around 20 questions, and there will be no negative marks. Some question might have multiple slides, so you should read everything and see everything, and then click for the answers. Make sure you have a good internet connectivity, and you should, if you are using a laptop, you can join with the menti.com app, or from the mobile you can scan this QR code. And when you are doing from mobile, make sure you don't receive any calls if you are answering from mobile. If the screen gets frozen due to internet connectivity issue, just refresh your browser. Do not close your Zoom window. It is suggested to use your laptop to connect to Zoom, and aggregate score of fastest finger along with the correct answer will be considered by the system to determine the final winner. And make sure you enter your full name. Last time I was seeing that there were some nicknames all were there, so better to use your name, because you might win some good prizes along with this. So around 9 people have joined. So there were around 40 people, 40 students are there. I'll request this student panel of KM also to join.
The students can join individually.
Yeah.
Of you. And please do not answer in the chat box that you see on the Zoom. That is not the way to answer. In the previous sessions, there were some of them doing that. So you can either type www.menti.com on your browser and enter this code, or you can use this QR code, scan it, and then that will take you to the corresponding web page, and then you can put in your name when it's asked, and then you can be ready. So please do not type in the Zoom. If anybody has any clarifications that are required, you may please post them in the Zoom box, the Zoom chat box right now.
Also, the prizes will be given.
Yeah, so the prizes will in the previous present winners have all received their prizes, and the prizes will include complimentary registration to the upcoming annual conference of the Heart Failure Association of India in 2027, and also an Amazon gift voucher.
The first will be a trial question.
What
Shall
is
we
the
start, sir?
question?
Like around 20 people have joined.
What is the question?
It will come, sir. It will come in minutes.
It will come. Next slide, it will come, sir.
So we are just waiting for people to join.
Quick. The name is visible.
So this will not be counted in the final marks.
Yeah, but what is the correct one?
That's first.
It's not
William.
brown world.
It's not
It is
round
Hurst.
world
It is Hurst.
anyway.
It is Hurst. The
Hurst.
answer is
Yes.
Hurst, but I think it
You
has
can
not.
read his.
Has not
You
been.
can read his name on the quote.
Yes.
Yes.
Observation.
Yeah.
Okay, next.
Okay. Now the question starts.
So now let's start the first slide. So there's a 26 years old female. She presented with dyspnea on exertion from 2 years. Her echo slides are shown. Which of the clinical findings is least likely to be present? Next slide, please. This next echo images. And the options are
Where are the options?
No options. It's come.
Yeah, but the clock has already started.
No, it's down set down. Loud P2 parasternal heave, continuous murmur, diastolic murmur.
To okay.
okay. So this is we can see the echo. There is a AST and there is mitral wall, severe mitral stenosis there. This is a Lutembacher syndrome. So most of the time, this oscillatory finding in Lutembacher syndrome of mitral stenosis, oscillatory finding will be diminished. They will be masked. So you might not get a mid-diastolic murmur at the apex. So that is a false answer. But you can get an MDM at the tricuspid area because of increased flow. Other signs, because they present very early with hypertension, loud P2 parasternal heave will be present. Any comments on this?
Proceed.
Correct.
There was a question, continuous murmur. If somebody writes continuous murmur.
Yeah, continuous murmur because of the AST, which is restrictive, can come as a continuous murmur. Here in this patient, you can see the continuous flow is there.
But it will be low. Okay, fine. Because it's a non-restrictive ASD. Fine, go ahead,
But
please.
enough
Sorry.
to produce a murmur?
Yeah, it's a
sorry.
The finding is
In
least
severe
likely.
mitral stenosis. Yes.
Huh?
So the question is least likely.
Least likely.
Least likely.
Yes.
Least likely. Continuous murmur. Okay, fine.
Okay.
Least likely continuous murmur.
Okay, fine. Go ahead.
Next slide. Next question.
Okay, this is the correct answer. Oh.
So this is a single slide where you have to identify the procedure being done. The options are please show the options. You can. So the 4 options are there: PFO device closure, LA appendage closure, VSD device closure, and cryoablation for AF. Okay, so most of you are correct. It's a L appendage closure device. It's a double seal device. It is a amulet device. You can see there is a low band, disc. So compared to the Watchman, which is a single sealing device, this is double sealing device, and this is the last before just deployment. We do the angio in RAO caudal view, where you can see the complete sealing of the L appendage. Next question. So this is again a 36-year-old female with exertional dyspnea from past years. Her saturation is around 97% at room air. Her autogram was done as shown. What is the likely diagnosis? One more lateral angiogram. Yes, you can show this. So here, so your four options are ruptured sinus of Valsalva, truncus arteriosus, orthopulmonary window, and patent ductus arteriosus. So again, most of you are correct. It's a autopulmonary window. It's a very rare case. She was an adult patient who came with this autopulmonary window. It was type 1 autopulmonary window. So you should know this when we give injection to the aorta, what are the causes which where we have simultaneous filling of pulmonary arteries also. So the options are here only. Truncus arteriosus can have this autopulmonary window, and patent ductus arteriosus also can have. But simultaneous filling with both wall we can see, and the defect is just above the semilunar walls. It is AP window. Whether in truncus, you will see the pulmonary arteries arising from the aorta, and the truncus wall will be below the defect. So it's a case of AP window.
Yeah, and arterial saturation is 97.
Yes,
so
sir.
it should be truncus.
Yes, sir. Correct. So next question. So here are the four tracings. These are basic LV loop, pressure volume loop, and the blood pressure tracings. You should see the first tracing. You can see first. I'll tell you that it's a patient of cardiogenic shock, and the other three tracing down. We have given a mechanical assist device to the patient. So you have to decide what mechanical device we have given. The next options will come to you. Can you see the options? So the first one is cardiogenic shock that I'm telling you. The other three options, as you can see, the other three device, Impella 2.5, IABP, tandem heart. Yeah, so half of you are correct. Like the option, correct option is B. As you can see in this, the second second option, the diastolic pressure is more than systolic pressure. So definitely this is IBP. That's the only condition where we get the diastolic pressure more than the systolic blood pressure. Similarly, impeller 2.5 and tandem heart, if you want to differentiate, you have to see the amount of cardiac output which tandem heart used to develop. It gives around 4 liters and impeller 2.5 will give 2.5 liters. So the blood pressure rises more in the tandem heart. So fourth is the tandem heart. And tandem heart, the inflow catheter is in the LA. So the blood comes from LA and goes to the femoral artery. While in impeller, the blood comes like it sucks blood from the LV. So the end diastolic blood volume will be more in impeller than the tandem heart. So tandem heart, it decreases the end diastolic volume because it sucks and it decreases the preload also. So this is taken from Grossman only, this previous edition. So you should read the hemodynamics. So that's today's homework. Next question. This is also a classical case with 40 years old male with dyspnea on exertion class 3 and LV dysfunction taken for angiogram for evaluation for LV dysfunction. So your options are ectatic coronaries, anomalous left coronary artery from pulmonary artery, anomalous right coronary artery from pulmonary artery, and coronary camel fistula. Okay, so few of you are correct. It's Al-Kappa. As you can see in the LA view, we are giving injection. They are hugely dilated right coronary artery and giving extensive collaterals to the left system, and the LED is draining into pulmonary artery. So it's a steal from the left system to the lower resistance system. Usually, 90% of the patient they die at the age of 1 year. In the adult survival is possible only because of this extensive collateralization. It's not a coronary camel fistula. Cameral means it has to drain into some chamber. If it is draining into any of the 4 chamber, it can be a coronary camel fistula. But here it is draining into a pulmonary artery. Any comments? It's not very clear. I think because of GIF images.
Cameral fistulas can also drain into the pulmonary artery, but they are generally shorter course and direct connection to the pulmonary artery.
Okay.
Here the route is via the left hand, descending hand, left coronary artery. So that is why it is a coronary Al-Kappa and not coronary.
Al-Kappa. Cameral fistula. Yes.
Coronary PA fistula. Coronary PA fistula is one of the commonest asymptomatic coronary cameral fistulas that is. Most common asymptomatic, they are very small, tiny. This is going through the left coronary system. Obviously, there's no doubt about it. Question.
Yes. Okay, next question. So on your screen, you are seeing a procedure being done. You have to identify the procedure. So your four options are balloon atrial septostomy, sinus venosus ASD closure, SVC stenting, balloon assisted ASD closure. Okay, everyone has voted, so we can see the answer. Okay, so half of you are correct. Like it's a balloon assisted ASD closure. It helps in the alignment of ASD device along the septum when there is a deficient aortic rim or deficient retrosuperior rim. So this is one of the procedure. One of the balloon assisted technique is a where it makes the alignment of ASD left atrial disc. So you should know the other techniques also. So we can go to the next question. So this is about a 25 years old female. She had a history of epistaxis, cyanosis, and clubbing. She was taken for angiogram. So your options are pulmonary vein stenosis, rupture sinus of Valsalva, pulmonary AV malformations, Hashimoto's syndrome. Okay, so most of you are correct. So it is a pulmonary AV malformation, and with the history of epistaxis and family history or multiple telangiectasia, visceral AV malformation, it fits into a diagnosis of hereditary hemorrhagic telangiectasia or Osler-Webb Endo syndrome. Next question. So a 55 years old hypertensive male presented to emergency with acute onset chest pain and dyspnea. He underwent a chest X-ray and a CT scan. So what is the diagnosis here? So your options are accelerations MI, pulmonary embolism, aortic dissection, or acute pericarditis. Okay, good. Everyone is okay. Good. So everyone is correct. So here, basically, those patients who present to ER without a ST lesion MI, there is a protocol, triple rule out test, where we can rule out pulmonary embolism, aortic dissection, and coronary artery disease with the CT. So this patient had a aortic dissection in descending type B dissection. Next question. So this is about a 40 years old male, known case of RST with severe MS and MR, presented with nausea and giddiness. Next step in management would be, after looking at this ECG, what would be your next step? Your 4 options will be coming in the next slide. So with looking at this ECG, whether your first option is to perform synchronized DC cardioversion, or you administer intravenous amiodarone infusion, or you administer IV magnesium and calcium gluconate to stabilize the myocardium, or none of the above. Okay, so answer is none of the above, because this ECG suggests you a bidirectional VT due to probably a digoxin toxicity. So first option, like perform synchronized DC cardioversion. Most of this digoxin toxicity arrhythmias are the mechanism is automaticity, and they don't respond to DC cardioversion. That you should remember. And if you want to give some medicine or injectables for digoxin toxicity, it has to be lignocaine or phenytoin. Those are the indication for ventricular tachycardia reversal. Then none of the above is the answer, because you have to check potassium or digoxin level. That should be the next step in your management for this patient. So basically, you should know the bidirectional VT is due to the digoxin toxicity in this patient. Next question. So this is 35 years old male with fever and dyspnea from past 7 days. What is the most appropriate next step in management? So whether it could be urgent pericardiocentesis if there are signs of cardiac tamponade, immediate needle decompression of the pleural cavity in the second intercostal space, intravenous thrombolysis for suspected pulmonembolism, and conservative management with analgesics. These are the 4 options. So the correct option is urgent pericardiocentesis because this X-ray, as you can see, this halo-like ring of air outlining. You can see this is a case of pneumopericardium. Most of the time, most common causes are trauma or fistula to pericardium from lung, bronchus, or esophagus. But this patient had Klebsiella infection. Apart from Clostridium, Klebsiella is also a known cause for causing pneumopericardium. Or sometimes it could be iatrogenic with the upper GI endoscopy or biopsy of sternum also. Next question, or maybe we can have a scoreboard. Okay, so this is the final, this is the halfway. Alka, Rajeshwari, Rohit Walsai, Ratnajit, Vidya PL, P Harish. Fastest is Anmol Jindal. Okay, we can have questions, then we can come the leaderboard. So you can read the history. This will be the multiple slide question, where a 75 years old gentleman with no prior comorbidities, he was found to have a mass in the tongue 6 months back, and he underwent surgery with wide local excision and modified neck dissection. Post-op ECG showed dynamic changes and with troponemia with elevated trop levels, and this is the ECG. So the echo of that patient. And then he was taken for angiogram. Next. You can. So I hope you have seen the slides. So options are acute fulminant myocarditis, Takotsubo cardiomyopathy, the NSTEMI, or none of the above. Yeah, it was a Takotsubo cardiomyopathy only. I think you have seen that LV angio where there was a apical hypokinesia and basal hyperkinesia, and the coronaries were normal only. Next question. So this is regarding a 10 years old school going girl. She had a sudden loss of consciousness and fall while running. Her ECG echo was unremarkable. There was no abnormalities, and she went ahead with exercise ECG. The finding was seen in first minute into stage 2 of protocol. What is the most probable diagnosis? So this is the ECG during the second stage of TMT. So your options are long QT syndrome, Anderson-Tawil syndrome, arrhythmogenic right ventricle cardiomyopathy, or CPVT. Okay, good. Most of you are correct. So it's a case of CPVT where there is during exercise there is increased number of ectopics in the exercise in the stage 2, and usually they end up having a bidirectional VT. So this is one more cause for bidirectional VT apart from digoxin toxicity. And coming to this long QT syndrome, her baseline ECG was normal. So long QT1, which usually has a syncope on exertion, will have a long QT. Anderson-Tawil has other morphological features, and ECG wise, it will have U waves. So those two are also ruled out. ARVC definitely will have a echo. Her echo was normal, so ARVC is ruled out, and ECG also will have a epsilon wave and RBB kind of pattern. So CPVT is the correct answer. Next question, please. So this is a pathological specimen of an infant who died due to severe heart failure and low cardiac output state. What could be the likely diagnosis? So your options are familial hypertrophic cardiomyopathy, endomyocardial fibrosis, endocardial fibrinolysis, or primary systemic carnitine deficiency. Yeah, most of you are correct. This is endocardial fibrinolysis. In the this asterisk marks, you can see smooth, shiny, pearly-like due to increased collagen. And probably it is a secondary endocardial fibrinolysis due to severe aortic stenosis. So sometimes you have a idiopathic, like in primary endocardial fibrinolysis, or in secondary causes like hypoplastic left heart syndrome or severe aortic stenosis. Those kind of scenarios you can get a secondary endocardial fibrinolysis. Other things like endomyocardial fibrosis is not a disease of infant, and you should know about primary systemic carnitine deficiency. This is also a cause for heart failure in children, and it's usually reversible. And today's homework is what is the role of carnitine in cardiac metabolism. So you should read that. Next question. Okay. So this is 45 years old male with weight loss and chronic cough, dyspnea, and ascites. I think the slides are misplaced. He has two more slides of echo. Otherwise, he was later on taken for cath. So your options are constrictive pericarditis, restrictive cardiomyopathy, dilated cardiomyopathy, and hypertrophic cardiomyopathy. Yeah, most of you are correct. So this is a constrictive pericarditis. You can see the discordance and the septal bounce and the traffic jam sign with the congestion of in IVC also you could make out. So this is a case of constrictive pericarditis. Next question, please. So 58 is old female with dyspnea of exertion class 3 since 6 months underwent a procedure shown. So what is not true regarding the procedure done? There is one more video and the options will be coming next. So what is the procedure being done for her and what is not true about the procedure? So your options are: it provides symptomatic benefit, it does not provide mortality benefit, indicated in patient with high risk for surgery, and not indicated in patient with septal thickness more than 20 millimeter. Yeah, most of you are correct. It's not indicated in patient with septal thickness more than 30 millimeter. So till 30 millimeter, it's still indicated in patient with high risk surgery. And although it does not provide a mortality benefit is still with the Mayo Clinic data. The septostomy only provides the mortality benefit, not the alcohol septal ablation. The procedure it is being done is the alcohol septal ablation. You can see a microcatheter from where the contrast is being injected in the septal, and there is a temporary pacemaker also for the during the procedure, and there is a one wire protective wire in LED also. So next question, please. So with the discussion in the previous clinical case, everyone should answer this. So 10 years old child referred with cardiomegaly, mild cyanosis, and ECG was done. What is the diagnosis? Your options are CCTGA, top with pulmonary atresia, tricuspid atresia, Epstein's anomaly. Yeah, most of you are correct. It's abstinence anomaly. Can You can see tall P waves, which are also called Himalayan P waves. Although Himalayan P waves are also described in tricuspid atresia, but you should look at the axis. Axis is more than 90; it's almost 100. Where, as we discussed in the clinical case, the tricuspid atresia, it will be left axis deviation. There will be no right ventricular forces. And CCTG will get Q waves in V1, V2. Those are not there. And moreover, in a 10-year-old child with stenosis and cardiomegaly, the best option will be abstinence anomaly. Next question. So this is again a echo clip where a 24 years old female presented with dyspnea progressive to functional class 3. What is the likely diagnosis? So your options are severe tricuspid regurgitation, severe aortic regurgitations, RAOV, RSOV, and perimembranous VSD. Yeah, most of you are correct. It's a ruptured sinus of Valsalva, which is draining mostly into the RA. There was a continuous jet, and along with that, there is a severe AR also, which is seen in your holodiastolic reversal in the thoracic aorta. Next question. So this also multiple clips will be there. Here it's a 5-day-old term newborn admitted in an ICU. He requires mechanical ventilation. What is the likely diagnosis? So your options are HLHS, supracardiac TAPVC, persistent pulmonary hypertension, large OSASD. Correct. It's a supracardiac TPVC. Most of you are correct. You could see there was a very small LA and a very small AST which was shunting right to left. So right to left shunting AST in a newborn. Always think of TAPVC also. There was a posterior chamber where all pulmonary veins are draining, and moreover, you could see the vertical vein and the innominate vein going into RSVC. You can see in the second clip, which was echo clip, which was shown. There was a continuous flow, and in the angiogram also it was seen. Okay, next question. So what are the classical indications for this procedure shown? So there will be 4 options in the next slide. What is this procedure and what are the classical indications? What is the most classical indication for this procedure? Your options are a DTJ with the intact ventricular septum and restrictive atrial septum, tetralogy of Fallot with severe right ventricular outflow tract obstruction, with intact atrial septum, or total anomalous pulmonary venous connection with unobstructed pulmonary venous drainage. Yeah, the procedure shown is balloon atrial septostomy, and the most classical indication was DTJ with the intact ventricular septum and restrictive atrial septum. Next question. So this will be the last question. So 2-year-old child with cyanosis since birth. CAT study was done. These are the oxygen saturations and the pressure. What is the likely diagnosis? So here are your 4 options. TJ with intact ventricular septum, DTJ with intact ventricular septum with AST, TOP with restrictive AST and non-restrictive AST, none of the above. Good. Most of you are correct. It's DTJ with intact ventricular septum. As you can see, that's the aortic saturation is less than the PA saturation. So this is a transposition physiology. RV pressure is more than the LV pressure. So this is intact ventricular septum, and RA-LA pressure are equal. So this is non-restrictive AST. And if you can see this RV pressure corresponds to your aorta, and the LV pressure corresponds to your pulmonary artery. So suggestive of ventricular arterial discordance, and it is suggestive of DTG with intact ventricular septum. So second is B is the correct answer. So this concludes this OSCE session. We'll have the leaderboards now.
So congratulations, Dr. Rajeshwari.
Rajeshwari?
So congratulations. So so you will receive your. You can please send your. I think you're the person who presented also, no? I think so. You can please send us your email address and your telephone number, and we will send you your Amazon gift voucher and your complimentary pass to the National Conference of the Heart Failure Association of India, which is upcoming in 2027. So congratulations. We had a good session. And Dr. Bhagwati, thank you.
Thank you, sir.
Venu,
Thank
sir.
So, Arun, you can now conclude.
Yes, sir. I think we had a wonderful session. Start with a nice talk by Dr. Jissa on statistical thinking and the approach to clinical research and statistics. And then the case discussion was very well presented by Dr. Rajeshwari. I thank the JIPMA faculty for bringing up this difficult case, and it was very well presented as commented upon by the examiners, Taragan sir, Sudhagama sir, Ajay Mahajan sir, and Dr. Santosh Satish sir. And I should also congratulate the student panel from State GS Medical College and KEM Hospital, Mumbai, Dr. Aditya, Dr. Praveen, and Dr. Pooja for the good discussion we had. And Dr. Bhagwati did an excellent job with the OSCE. I thank the entire team, Chopra sir, Venu sir, Harikrishnan sir, Abraham sir, Dr. Sajan, and the entire team from Heart Failure Association of India, Vinay in the Hallmark events, and Sumita and the Sun Pharma Coronas Division for their support. And thank you all for joining. I hope all of you made use of this session. The case discussion was excellent, and we all learned quite a lot. Although the case is difficult, just how we go systematically that helps you to even to tackle difficult cases in a structured clinical manner. So thank you all, and good night, and we'll join next month for the next episode of the Heart Failure Masterclass. Thank you. And good night.
Arun, good night. Good night, Dr. Tarakan.
Thank you, sir. Good night, sir.
Dr. Rajeshwari, please. Yeah, we can. Vinay, you think you can collect that?
Sure. Okay. Thank you.